Hello, future IBCLCs, and welcome! If you're getting ready for that big exam, you are in exactly the right place. We're about to do a super fast, high-yield rundown on the critical link between thyroid conditions and lactation. We're going to cover hypothyroidism, hyperthyroidism, and postpartum thyroiditis. Let's jump right in.
Okay, so imagine this. You're with a client and you've gone through your whole lactation consultant playbook. The latch? Looks great. Positioning? Perfect. They're feeding frequently, right on cue, but that milk supply just isn't budging. It's a really frustrating situation, and I promise you, it's one you're going to face. So what's next? What are you missing?
Well, here's the thing. Sometimes the root of the problem isn't mechanical at all, it's physiological. We have to learn to look beyond the breast and think about the body's endocrine system. And specifically, we're talking about that small but incredibly powerful gland in the neck, the thyroid.
This right here is so important for you to understand. A person might not even know they have a thyroid issue. They might feel fine otherwise, but their very first symptom, the thing that makes them call you, is trouble with their milk supply. This means you, as a lactation professional, are truly on the front lines of spotting these potential red flags.
Okay, let's kick things off with our first condition, an overactive thyroid, also known as hyperthyroidism. We're going to focus in on Graves' disease since it's the main player here. And then we'll contrast this with its opposite, hypothyroidism, which is directly tied to that low milk supply issue we just talked about.
All right, here is your first key statistic for the exam. Just lock this one away. When a pregnant person has hyperthyroidism, 95% of the time the cause is Graves' disease. It's an autoimmune condition where the body basically tells the thyroid to work way too hard. So for the exam, when you hear hyperthyroidism in pregnancy, your brain should immediately think Graves.
Now, for one of the most important takeaways of this whole explainer, so listen close. Even with all that's going on in the body, hyperthyroidism generally does not impact lactation. An overactive thyroid is not a typical cause of low milk supply. But, and this is a huge but for your exam, the opposite is true. Untreated hypothyroidism and underactive thyroid is a well-known cause of low milk supply. The good news is that thyroid supplementation is safe during lactation and can make a world of difference, improving both the parent's symptoms and their milk production.
So what about treating hyperthyroidism? Well, there are two main drugs you need to know. First, there's propylthiouracil, or PTU. The big concern here is that it can be toxic to the liver, so it is not the first choice. Then we have methimazole. This one is considered safe during lactation in low to moderate doses, making it the recommended first-line therapy. It's really important to know that both of these drugs can pose risks during pregnancy, but when it comes to lactation, methimazole is the one to remember.
All right, next up is a condition that kind of ties everything together because it can actually look like both hyper and hypothyroidism. It's super common, but it's often missed or misdiagnosed in the postpartum period. We're talking about postpartum thyroiditis.
So what is postpartum thyroiditis, or PPT? It's an inflammation of the thyroid that happens after birth, and it is the single most common thyroid disorder in the postpartum period. For your exam, you absolutely have to know that it typically happens in two phases. First, there's a brief hyperthyroid phase, which is then followed by a much longer hypothyroid phase. And it's during that second, low thyroid phase, that your client is likely to experience that frustrating drop in milk supply.
And look at these numbers. It's incredibly common, affecting maybe as many as 1 in 6 postpartum individuals. It's often missed because the symptoms, fatigue, anxiety, feeling down, can easily be brushed off as just the baby blues or normal postpartum exhaustion. A key diagnostic tool is a radioiodine uptake test. In PPT, the uptake is decreased, which is how doctors can tell it apart from Graves' disease, where the uptake would be increased. This sometimes requires scans using things like iodine 123 or technetium 99, and if your client needs one of those, they'll have to temporarily stop breastfeeding. It's all based on half-lives, about 13 hours for I-123 and 6 hours for technetium 99.
Okay, let's pull all of this together into your exam essentials, your ultimate cheat sheet. A couple last crucial points on postpartum thyroiditis. Antithyroid drugs, like methimazole, are not used to treat it. Why? Because the hyperthyroid phase isn't from overproduction. It's from the inflamed thyroid just leaking out stored hormones. And this is a really important counseling point for the long term. About 25% of people who get PPT will develop permanent hypothyroidism within 10 years.
Let's lock these in one last time. Hyperthyroidism in pregnancy? It's going to be Graves' 95% of the time. Does it cause low milk supply? Nope.
The first-line drug for it during lactation is methimazole. We want to avoid PTU because of liver concerns. And postpartum thyroiditis is the #1 most common thyroid issue after birth. And don't forget our key points on its opposite. Untreated hypothyroidism is a cause of low milk supply, and treatment with thyroid hormone is both safe and effective during lactation.
So there you have it. You're now armed with the essential facts on hypo, hyper, and postpartum thyroiditis. You know that when all the latches and positioning fixes aren't working, the thyroid could be that hidden piece of the puzzle. So the final question is for you. Knowing all of this, how will it change your approach? How does it empower you to be a more thorough, insightful, and effective IBCLC right from your very first client? Think about that, and good luck on your exam.